Hey, everybody. Thanks for tuning in and joining us again on Pulm PEEPs today. We are very excited for a special episode today. Christina and I have been working on this and anticipating it. So we're really pumped to be sharing some new content with you. Christina, how you doing? How's your week going?
Hey, Furf, it's going well. Doing great. A lot of, I think, trainees are thinking about transitioning to the next steps and hopefully getting out some content that can help with that transition for them.
Yeah, absolutely. We have really been dedicated on Pulm PEEPs here to talking about trials, things that can guide your therapy. We've done some landmark trials in our rapid fire journal club, certainly in our case files episodes and our consults episodes, we talk about key topics. But we've always wanted to combine the goals of the podcast to provide pulmonary and critical care education with some of the more rigorous elements that exist in academia. Peer review journals are still the gold standard. That's where we get most of our great content and information. And as great as we think that our podcasts are, they haven't always had that peer reviewed and journal partnership behind them. And so we've been thinking about ways that we can do more hybrids and more collaborations to add those two great elements of these different formats and provide education for everyone.
Yeah, couldn't agree more, Furf. And I think keeping in line with those goals, as you said, we're so excited to announce our new initiative today, which is a Pulm Peeps collaboration with the British medical journal Thorax. BMJ Thorax is one of the world's leading pulmonary and respiratory medicine journals and publishes groundbreaking pulmonary as well as critical care experimental research studies. And one of the things that I tend to read very often and share articles with trainees. It's an official journal of the British Thoracic Society, or BTS, and is regularly shaping the landscape of pulmonary and critical care medicine. In addition to the mission of advancing research in clinical care, Thorax is dedicated to medical education as well. And we're so excited today to be joined by one of the associate editors for education, Christopher Turnbull. Chris is an honorary research and respiratory medicine consultant at Oxford University Hospitals. In addition to his role as associate editor for education at BMJ Thorax, he's also a prominent researcher in sleep-related breathing disorders. Chris, it's so great to have you on Plum Peeps today and to be working together with you on this project. And love if at this time you could tell us a bit more about some of BMJ's educational missions, as well as the fantastic journal clubs that you've been spearheading.
Thanks very much, Christina. Yeah, no, really excited about this collaboration as well. So really the idea behind this, and from the point of view of Thorax, is that the BMJ Thorax has a wide international readership, and it publishes high impact peer reviewed publications already. But the vision of this is to provide high quality educational materials to support trainee fellows and allied healthcare professionals, along with consultants who make up a large portion of the readership. Really excited to be doing this podcast today, which is going along the monthly journal clubs that we have in Thorax. These are articles which are mainly submitted by fellows or trainees, and what they do in those articles is choose 4 practice changing articles on a theme which have been published in a high impact journal within the last roughly 12 months. In that, I help the fellows in choosing and setting up a theme for those. And anyone who wants to help and contribute in that way, I'd be delighted to talk to them further about the remit and the idea of those journal clubs tied in with these podcasts.
Yeah, they're great features. And I think one of the reasons we're so excited about this is it really feels a need for us here at Pulm PEEPs and hopefully for our listeners as well. As I've stated, and as the listeners know, we do a lot of discussion of sort of the landmark trials. A lot of these trials are a little bit older. They guide the practice. They answer that question, why are we doing what we know we do often in the hospital, in the clinics, or in the ICU? But part of being a good pulmonary critical care doctor is staying up to date on the literature, and that is not easy. There's a lot of literature out there. And so having somebody synthesize it for you really helps you say, okay, I know this came out in the last 12 months. It's either changing how I practice or changing how I think about my next research questions or how I evaluate patients. So we love to be talking about some more recent articles that maybe haven't quite gotten to this point where everybody knows about it. So we love doing this with you guys because I think there's a lot of benefits to this collaboration. I think there's a lot of audience sharing that we can have, certainly reaching out to more people in the UK and your great readership, and we have our listenership as well. Chris, I was hoping you could share a little bit more about the goals of us working together and expanding on those goals from the journal clubs that you're already publishing, which are so great.
Yeah, thank you. Of course, happy to share the overall goals. Really what we're wanting to do is expand upon BMJ Thorax, already excellent evidence-based medicine. What we want to do with these is to reach a wider readership, a broader audience from in the US, in the UK and beyond, and also really reach a wider readership of trainees, fellows, and allied healthcare professionals, along with physicians. The overarching aim with education in thorax is that we want to bring content that people can easily access from a topic or a theme, rather than opening up a journal or a journal landing page in that traditional contents layout, which is divided by original research, and instead come in via theme, perhaps focusing on airways diseases we will be doing today. And really another opportunity to highlight some of the great work that's being done by our fellows and trainees from across the UK and internationally.
Yeah, absolutely. I think that's how clinical questions are often asked. Or I have this patient, they have airways disease. I really need to know an answer to this question. And so trying to mimic that and what we're doing here, I think is great. And as you said, always want to amplify the work that the great fellows are doing. They're dedicating so much time to learning and sharing their knowledge with other trainees. And we always want to expand and amplify their voices if possible. Before we move on and meet our fantastic fellow joining us for this first episode, I'm just curious, Chris, if there are any podcasts that you're listening to regularly. If the answer is no, that's fine. But I'm always interested to what people are listening to out there and great content that other people should tune into.
Yeah, thanks. There is lots of great content out there already. I completely agree. And I think one of the things I'd really love to highlight is the existing BMJ Thorax podcast, which is hosted by Podbean. These have great content there. One of the articles recently was looking at the link between asthma and obesity. Another was discussing the BTS, or the UK National Guidelines on Managing Pleural Disease. Personal perspective as well, I always like listening to podcasts from out of the blue. And BMJ Best Practice, I find, is a really helpful place to get content perhaps outside of what I would normally listen to in the world of respiratory medicine. Of course, I should say it as well, outside of Pulm PEEPs. And hopefully with this collaboration, what we can do is something a bit different to those podcasts, and bring something which really focuses on educational content and bringing in a number of articles across theme to really work on a topic area.
Absolutely.
Yes, definitely. Thanks so much, Chris. And as you mentioned, a lot of great resources out there. As you said, hopefully, though, we can bring something new and just get it into people's queue is one of our goals as well. But so excited today to finally meet our most important guest today, who is Imran Howell, who wrote the BMJ Thorax Journal article for the February 2024 issue. Imran is currently an asthma fellow at the Newfield Department of Medicine, University of Oxford. He's currently in his third year of his PhD. And we couldn't be more excited for you to be joining us today, Imran, and kicking off this Pulm PEEPs BMJ Thorax collaboration.
And thank you. It's a pleasure. Thanks for inviting me.
Yeah, it's our pleasure. So it's great to have you in the show. To start, I was hoping you could tell us how you ended up picking the 4 articles we're going to review. You know, how this process is really interesting. How did you decide on a topic that you wanted to cover? And how did you sort through the many studies that are out there to hone in on these 4?
Yeah, as I'm doing a PhD, fortunately, I've got a lot of time to read widely. And these are 4 papers that I've come across in the last year, and I found that they stood out as really important in the field. My research background is asthma and airways disease, so 3 of them are around that topic, but there was a really interesting TB one, so I've also included that. But I think all of the studies see the question, the current state of clinical practice, also probe at the nature of respiratory disease.
Yeah. Notoriously, PhD is not busy at all. So much time to do reading. It's awesome. And yeah, sometimes there's just a great study that jumps out, and even though it's a little bit outside your field, you just get pulled into reading it. So I'm glad that we're adding a little variety to the mix. So let's dive in. The first study that you talked about was about the STAR-2 trial. This was about blood eosinophil-directed treatment for COPD exacerbations. We've done a whole series here on Pulm PEEPs on COPD, and certainly encourage people to listen if they're interested. And we've talked about how the cornerstone of therapy for exacerbations has generally been oral steroids. However, we also have discussed the exact dose and durations of steroids as a common question that comes up. It's been looked at multiple times, and this trial started focusing in on that. So can you tell us about the purpose of this trial and what was being studied?
Yeah, so it's an exciting study, and you really challenge that cornerstone that you just mentioned, really. And it's close to my heart because it's conducted right here in Oxford, and it was the main trial lead was Mona Baffadel. He's one of my supervisors, but also Chansi Ramakrishnan worked on it, and I worked with him here as well for a couple of years. And as I said, it's to challenge the orthodoxy that steroids are a one-size-fits-all treatment for COPD exacerbations in primary care. And it builds off the back of work that actually Mona did the last 10 years, really. We know that steroids target eosinophilic inflammation, and we know that they're harmful. But these harms include serious things like diabetes, cardiovascular disease, osteoporosis, are all cumulative. So the more you give people, the more likely they are to get a lifetime. So it really comes down to a question of, is the risk worth the benefit? And this multi-center, double-blind, randomized, placebo-controlled trial tested that hypothesis that actually all steroids are only effective in exacerbations where blood eosinophils are raised.
Such an exciting article, Imran, and so glad that it really is, as you said, hit close to home by the supervising authors for this. And really important too, and I think blood eosinophil count, I know in previous podcasts and just like in general, kind of day to day, it gets brought up by fellows and trainees, and like, how do we decide what we're going to do based on the baseline blood eosinophil count, and will that change management? And I'm wondering, Imran, can you tell us a bit more about the intervention for this specific study and how the control and treatment arms differed?
Yes, so essentially there were two groups. So there was a blood eosinophil directed treatment group, and there was a standard care group, where participants were randomly assigned one-to-one to those groups. And in the blood eosinophil directed treatment group, they had a point of care blood eosinophil test, which could measure in percent. So it's high, which is greater than 2%. They were randomized they would get prednisolone treatment. If it was low, less than 2%, they would be. And then obviously in the standard treatment care, they'd all receive prednisolone, irrespective of eosinophil status. The treatment was perhaps not exactly what we usually give. I think this study was designed probably around 10 years ago, so the guidelines were slightly different then. Prednisolone course was 14 days of 30 milligrams per day, and all patients received antibiotics. And I think these was a pragmatic solution based on the guidelines the final trial was designed, and that may be a criticism of it. I think it was a choice that was made. The primary outcome was the rate of treatment failure, which they defined as retreatment with antibiotics, steroids, or leading hospitalization for any cause or death. And the participants had to have had the COPD and at least one exacerbation in the last year on triple therapy. And I suppose one important caveat to note, another potential criticism of the study, is that although it was designed initially as a superiority trial, and that was off the back of Mona Baffadel's previous work, unfortunately, there was an error in the randomization code during the study. And so for data lock, it was converted to a non-inferiority design.
Yeah, important things to always keep note of. And every trial has the trials and tribulations. So we always have to note limitations. But overall, I just love the way this is studied. You point out that some of these standard treatments have changed some in terms of standard duration or everyone receiving antibiotics. But in some ways, it's a strength here because you know that you're taking that out of the equation. Everybody got a long treatment therapy. Everybody got antibiotics. Less likely that there's some missing element of their treatment there based on just this design. And then I also just love any trial now that it's about personalization in medicine and using a point of care test to rapidly decide how you're going to treat patients. I think we've all been honing in on the fact that we need to enhance our patient selection, both for clinical treatment, but also for trial design, right? To find out which therapies are the best and for which subsets of patients. So I think this is a really great structure. All right, so we have our framework. We're treating patients with COPD. Most of them are on triple therapy. They've had exacerbation in the past year, so presumably they're gold C or D based on those symptoms and exacerbation rates. Pretty sick overall. And we're giving them 2 different therapies. Great. What did we end up finding?
There were, in the blood eosinophil directed group, there were 14 treatment failures, which equated to 19% in the 30 days post-exacerbation. And in the standard care group, there were 23, so 32%. It's actually more numerically, although as I said, it wasn't powered for superiority anymore, but it definitely did confirm non-inferiority. And additionally, there was no difference in the adverse event between the groups. You said it's all about personalized medicine, and I think we need to move away from just giving everyone steroids. A lot of that data was from quite a long time ago, and actually it's not that convincing really. And I think this study really adds a lot to what's already out there. 90. And in my opinion, it's practice changing. And I would certainly try and avoid using more steroids in a non-hospitalized setting, in non-eosinophilic COPD exacerbation. And I think this is particularly pertinent in the UK, where we tend to use a lot of rescue packs. I'm not sure what the practice is like in the US, but a lot of people just treat themselves and we have no idea what their phenotype is really. And I think we may be exposing people to more harm than benefit in this case.
Thanks, Imran, for sharing that. And I think, as you mentioned, at the point of after reading, I think, each article, specifically like when we do our journal clubs, and the purpose of this is to ask yourself, like, how are these findings going to change your clinical management? Is it enough to change it? Is it not enough to change it? And I think it was interesting how you pointed out this was initially designed to be a superiority trial, which was then changed to non-inferior trial. And Chris, based on this type of non-inferiority study, would this be enough to change your practice pattern, or would you be waiting for additional follow-up or further studies to change your mind?
No, absolutely. I think this is a practice-changing study. I think this really challenges us to do when we see patients is to try to think more carefully than just saying someone who comes in with breathlessness and perhaps cough, who has a diagnosis of COPD, has a COPD exacerbation, and that's it. And I'm just going to give them all of the non-personalized therapy. I think it challenges us to think, with this patient in heart failure, does this patient have an infection? Is it viral? Is it bacterial? Will they benefit from steroids? So I think it really challenges to think more carefully about that label. I think it also challenges the system in that I think this is a fantastic finding. The challenge now is, can we go out and deliver this in primary care? As Imran mentioned, in the UK, a lot of people have rescue packs. So they're not even seeing a healthcare professional before starting steroid treatment. Who often, by the time we see them in hospital, they will have initiated that therapy. And I think it does challenge us to think about that practice as well.
Yeah, those are great points. Very interesting. I'm excited to move to our next one. This next trial is a much larger randomized trial on a bigger scale. It's looking at providing nutritional support to household contacts of patients diagnosed with tuberculosis in India. I was hoping you could share what the rationale behind this intervention was. This is pretty interesting. And when I first read it, I was like, okay, how is nutritional support going to have an impact? Curious if you can give us some background.
Yeah, it's incredible, right? It blew me away when I read it, and it definitely humbled me in showing what's possible in a clinical trial design. Here I am doing a small single center study and giant sort of undertaking. The background is that tuberculosis is a huge global health problem in low and middle income countries. We don't see as much of it in Western countries, if you like. And it's closely linked to poverty. And there's a strong link between undernutrition and TB incidence and progression from latent to active TB, but also mortality after you get TB, drug toxicity, delayed conversion, and current. So this study investigated whether macro and micronutrient supplementation for 6 months could reduce TB incidence in the household contact patients over a 2-year follow-up period. I think that's a really interesting, angle to come at it, because we might obviously expect that people with TB themselves would do better if they had better nutrition, but this is really interesting in showing that the transmission can be affected just by nutrition contact. And so I really like this. Not only did they ambitiously tackle a very hard research question in hard-to-read population, but I think they did it in a really clever design. Operationally, you can imagine you must have done like an Amazon warehouse to deliver all these food parcels to a huge state in India. And it would have been almost impossible to randomize each household or within a household to receive different food packages. So instead they used a cluster randomized control trial design. And I think that's a really great use of that type of methodology. And so they used 28 TB units, consisting of around 100 households each. And that's how they went about the study.
Thanks, Imran. I'm so glad that you picked this article to include in your journal club, because I think I wouldn't probably read this. This is not something I would necessarily read day to day. But I think seeing this, as you mentioned, so important from a public health perspective, as well as the methods that were used. And it looks like there were over 5,000 people in the intervention arm and over 4,000 in the control arm. So a much larger study than the first one we talked about. And in both cases, the diagnosed patients were provided with nutritional support. But in the intervention arm, household contacts were also given some nutritional supplementation. Imran, can you walk us through a little bit more about how the intervention worked?
Yeah, so as you mentioned, the household contacts, which was the main focus of this paper, received a food basket containing about 750 calories and 23 grams of protein a day per person, as well as micronutrient pills for the duration of TB treatment. And there's a section in there about how they made the food similar to what people would usually eat as well. And that cost $4.75 per month, quite cheap. And after 2 years of follow-up, there were 122 incident tuberculosis cases in the control groups, that's 2.6%, and 96 incident cases in the intervention group, so 1.7%, which equated to a relative risk reduction of biologically confirmed TB of 48% in the intervention group, which is pretty big. And again, that equates to 30 households that need to be provided nutritional supplementation to prevent one tuberculosis case. Incidentally, all of the TB patients who were in the study were also treated with a food basket containing a higher calorie and protein sort of content, which cost $13 a month. The results of that were published separately in a Lancet Global Health paper, but the headline is that weight gain in the first couple of months of treatment, so the 6-month treatment course, was significantly associated with reduced mortality at 6 months.
It seems like a really pretty massive relative reduction in TB diagnosis from this intervention, which I think has great public health implications. And Imran, from your reading, does this type of intervention seem like it could be both cost effective as well as feasible to implement to, other parts of the country or other parts of the world?
I think so. I think they referenced modeling that's previously been published that supported that it would be cost effective, and I think in low and middle income countries, I think it would be, and I think if you consider that each case of TB will lead to many new cases later down the line, so you can really see how if you just reduce transmission and that by ensuring that the contacts have adequate nutrition or TB vaccines one day, then that could really have an exponential impact in reducing TB cases.
Yeah, that's a really interesting, great perspective, Imran. So let's turn to the third study that you selected. This study evaluated how the airway microbiome mediates the interaction between environmental exposure and respiratory health in a cohort of adults living in China. Imran, can you tell us a bit more about the goal of the study and the cohort that was used to answer the hypothesis question?
Yeah, this was again another interesting study. It was a bit of a harder read than the other ones, but it's well worth it and really interesting. We know that exposure to toxicants and pollutants causes lung disease, and also that COPD has a huge global. So if we can try and prevent the sort of development of COPD, that's really important. But we don't know about the sort of role of an altered airway microbiome in perpetuating this lung damage or mediating lung damage. And it's a bit of a chicken and egg problem. Does the inflammation caused by the tox shape the airway microbiome and predispose to disease onset, or does the existing damage that's caused by the toxicants lead to an altered microbiome? But we don't know whether it actually has a sort of causal role in there. And actually, part of the problem is we don't even know what a healthy airway microbiome signature even looks like. These authors used a giant province-wide COPD surveillance program in China with adults aged 40 to 81, and they did a cross-sectional studies. Again, they can't prove causality in this, but they assessed the relationship between airway bacterial and fungal microbiome with geography, different exposures, health outcomes, and also airway diseases. So participants were randomly sampled from random sites using a multi-stage probability-based sampling. And they weren't included if they'd lived in their current residence for less than 6 months, or if they'd used antibiotics in the months prior to the sputum sampling. As I said, it was a really large study. They had over 1,600 people who did all the clinical measures, including spirometry, exposure assessments. They all got induced sputum, and this sputum was tested with different methods, bacterial and fungal identification and metagenomic analysis. And I was particularly impressed with the size of the study for one thing, but also that they really had a detailed clinical and exposure phenotyping, which I think was really important, and their commitment to good quality induced sputum. And from personal experience, I do induced sputum in my work, and I know how frustrating this can be to collect. So collecting it from 1,600 people was pretty impressive.
Yeah, absolutely. Both this and the last study are just a testament to the unbelievable work people are doing to try to randomize this many patients and collect samples with a high fidelity measurement and do such rigorous research techniques is truly impressive. So I'm glad that we're talking about this work. So as you highlighted, the study is looking at this intersection of environmental exposures, airway inflammation, and the microbiome alteration. And I was hoping you could talk to us about the key findings regarding the association between smoking, PM 2.5 concentration, and the microbiome variation.
Yeah, so interestingly, geographic district had by far and away the strongest contribution to the variation in microbiome profile, with nearly 11 times greater than smoking, which was the second highest association. And make of that what you will, really. I think it's a very interesting find. Smoking was mainly associated with bacterial variation, while PM 2.5 air pollution concentration was predominantly associated with fungal variation. And they did try and adjust for geographic variation. They found that these associations still remained. In terms of clinical relations, I'm condensing this down a lot. The paper was quite complex, but there was some complex mediation analysis that showed that microbiome tended to mediate the effect of air pollution and smoking on clinical outcomes. So that was forward mediation, but there was also some reverse mediation, i.e. sort of the damage to the lung to affect the microbiome with smoking. Again, this has showed a similar picture where it tended to be through bacteria for smoking and fungi for pollution.
Thanks, Imran, for summarizing those points and giving us some highlights. I agree with you. When I read this, I had to read it a few times to understand some of the results in the analysis, but that's fair. It was a great study, though, overall. And in your summary, Imran, you mentioned that the geographic district was identified as having the strongest contribution to the variation in the microbiome profiles, specifically surpassing smoking as the highest association. So this lends me to think of the question of how can we then pursue targeted public health interventions based on the findings that these authors are reporting. And Chris, I'm interested to hear what you think are some potential implications of this geographic variation in the microbiome, and any thoughts on how public health interventions targeting the microbiome may be impacted.
Yeah, thanks, Christina. Certainly, it's a fascinating study and a real massive piece of work for the authors to put this together. I think for me, I come back to the importance here in terms of air pollution and smoking in being something which this could champion as things that we should be trying to tackle, cutting down on air pollution and giving people the opportunity to stop smoking. So I think the really important and striking things in the study were the association between smoking and air pollution, and really raises again the challenge that we should be looking at trying to make our air cleaner and give people the opportunity to stop smoking. I think it's important to recognize that this is cross-sectional work and it doesn't really have an intervention yet proposed for this. Certainly, I'm not sure how you would go about targeting the microbiome as a target. That certainly would be something which would raise some alarm bells potentially in terms of antimicrobial resistance there. And I think probably this highlights the importance of targeting clean air and smoking more widely in public health measures.
Yeah, absolutely. Absolutely. I feel like there's been so much ongoing recent attention appropriately to pollution, lung health in general, especially in the era of evolving climate change and how that's impacting a lot of the particulate matter, especially in these high pollution areas. Always keeping our mind focused on these and then thinking about the role that us as physicians have in a public health perspective, I think is important, like this study highlights. The other interesting component of the study is thinking about the airway microbiome. I think we're getting more understanding of this, still very nebulous, still a big black box, but something that we recognize is really important. So Imran, this is introducing in this study this concept of an airway microbiome health index, which kind of declines in disease progression from healthy patients to pre-COPD to frank disease states with COPD. I was hoping you could share more about this index and how you think it might end up being utilized in clinical practice. I think this is going to be something that evolves over the rest of our career and may become applicable to bedside and not just in research studies in the future.
Yes, as we said, it was a cross-sectional study, so we didn't have the benefit of time to see if people developed disease, but a large proportion of the people who were sampled were healthy time and had normal lung function and no symptoms and things, because this was a screening program that they were coming from. But then the proportion of people did have disease, and what they noticed was that the people who had disease, their microbiome, bacterial and fungal, tended to be altered in the same direction across the sort of various airways diseases that they found. So they proposed that there's a sort of a pan-disease airway microbiome signature. And again, through very complex methods, they modified an existing gut microbiome health index and they whittled it down to 22 bacterial and 63 fungal genera. And they picked those because they're the ones that are most often on the sort of common tests that you can do, and created this Airway microbiome health index. And they showed that had a sort of rock area under the curve of 0.79 in distinguishing health from disease. Personally and realistically, this is too early before we can use this sort of in-depth in clinical practice, and it's purely cross-sectional study. But you need more studies looking at prospectively over a long follow-up period, and that may be quite challenging because you might need quite a long time to establish causality. But I think it does hint that maybe there's a potential treatable trait here, and I think it's certainly worth pursuing in the future and looking in if there's any, particularly the mechanisms of why the microbiome might be mediating more damage and things. And in that, you might be able to find a target that isn't an antibiotic. You might be able to find something else that you can target instead.
Yeah, that sounds great, Imran. And again, you and Chris both alluded to the cross-sectionality of this design. Some great data, but a little bit too early to make specific interventions based on this. But as you mentioned, Imran, more steps and more to come. Fantastic. Let's turn to our fourth and final study you looked at, Imran, and this was looking at RSV infections. RSV infection and implications of disease in children and adults has been one of increasing interest. And this study specifically looks at the association of RSV infection and infancy and childhood asthma. Imran, you noted that prior studies of RSV infection have been confounded because a control group of children without RSV infection in infancy have not been previously included in the journal club that you published in February 2024 issue. Can you tell us more about the author's study design and the INSPIRE cohort utilized for this specific study?
Yeah, again, so this actually, this might have been my favorite of all the studies. It really boils down to the properly understanding whether RSV and the severity of RSV infection in infancy is independently associated with developing childhood asthma. Now, they pointed out that, the authors pointed out that previous studies have focused exclusively on severe RSV infections. Everyone had RSV, it's just whether they were hospitalized or not. And then they compared those two groups. But actually, that's very confounded because the people who get severe RSV infections may already be genetically predisposed in some way to developing childhood asthma. No. So this study, which was done in Tennessee in the USA, mitigated this by comparing RSV infection with a control group that had no infection. And they did this with a really sort of rigorous methodology. So it was a prospective birth cohort of healthy infants that were born at term and children recruited 6 months or younger, beginning or before the first RSV season. And the way they did a sort of passive and active surveillance to work out whether they had RSV infection in that first year. And so they basically got families to call them and come and get tested if they had symptoms. And they did a nasal wash, an RSV PCR. But additionally, at 1 year, they also measured RSV serum antibody titers by ELISA. So trying to miss any of the ones that didn't contact them and try and get a really true prevalence. And then children were classified as either being not infected or infected with RSV in the first year of life and then followed up for 5 years. And the primary outcome included was asthma diagnosis or asthma medication use at 5 years of age. Now, that may be not a very strict primary outcome in that it was a primary care physician diagnosis, but I think it was a pragmatic one.
Yeah, definitely. It's how most real world asthma diagnoses are made, and those are patients that are getting treated and getting medication. So it seems like a reasonable diagnostic criteria. This article continues the theme of being in awe of researchers. This is a really hard question to answer. I think, as you pointed out, the previous studies in this space have always relied on looking at cases that you already knew had RSV infection and then trying to compare to a baseline rate of asthma diagnosis or compare to patients who had less severe infection. But to take a group of healthy infants and follow them prospectively to really look at this RSV exposure, especially starting from such a young age, and especially relying on actual RSV PCR and antibody testing for the diagnosis, is just an unbelievable undertaking and gives us a really healthy control cohort to compare to. So really the question at hand of whether or not getting this RSV infection is increasing your risk of asthma going forward in the first few years of life. So a great setup, and I was hoping you could tell us what the key findings of the study were.
Yes, again, it was another very large study. So 1,946 children were enrolled and 1,741 were assessed for RSV infection at 1 year. And the proportion of children with RSV infection during infancy was 54%. That's in 944 people. The proportion of children with 5-year asthma was lower in those without RSV infection during infancy. So it was 16% compared with those who had RSV infection during infancy, which was 21%. So that's a 26% lower risk if you didn't get RSV in your first year of life for developing 5-year childhood asthma. And there's some really nice graphs actually in the paper showing that the severity of RSV infection was also associated with an increased risk of 5-year asthma as well.
Yeah, thanks so much, Imran. And we'll definitely post links so that you can go to these articles directly and review them for yourself. And as you noted, Imran, some really nice images to be able to look at to depict some of the results from this one. And wanted to end with another question from this study, Imran. You also noted that the RSV infection was more strongly associated with non-atopic asthma than atopic asthma. And given your kind of clinical and research background in airway disease, Imran, wondering if you could share potential possible explanations for this differential, and do you think that this may impact development of targeted interventions against RSV in the future?
Yeah. So as a sort of overall explanation that they suggest for their main sort of outcome, they suggest that early RSV infection may lead to long-term reprogramming of the early life immune response in the airways through T-cell memory responses. And that's backed up by some of their in vitro work as well. I think the fact it predisposed more to non-atopic asthma was interesting, although I'm not completely convinced by that because it was quite a small sample size from the secondary analysis. And they did also get atopic asthma as well. So I'm not totally sure about that. But this did attempt to explain that with some other from their previous work that they'd done, that RSV may impair type 1 immunity, so that the immunity that's sort of antiviral, antibacterial. So potentially, if that type 1 immunity is impaired, maybe these children are just getting recurrent bouts of viral wheeze over the sort of next 5 years, and that's inverted commas non-atopic asthma. I think ultimately it needs more mechanistic work to show it. I think the key clinical message to me is that the estimated proportion of 5-year asthma cases that could be prevented by avoiding RSV infection during infancy was 15%. Now, this is a common condition, and that's quite a large number when you think about how common asthma is in childhood. And this is really where I really like the study and the timing of the study, is that this is where the new RSV vaccines in pregnancy or the RSV monoclonal antibody therapy in infancy come in. Not only do these treatments prevent severe disease and healthcare utilization at the time of infection, but they actually may also, as time will tell about this, prevent some people from developing asthma in childhood. And considering the prevalence of asthma and burden on the healthcare system, I think that would be a huge achievement if that's the case. And it's an exciting prospect that will hopefully be borne out in long-term data.
Yeah, absolutely. I also want to highlight that just how impactful this could be. You look at the raw results that you discussed, and absolute risk was reduced by 5%, but the relative risk was reduced by 26%. And over the cohort of this prospectively followed infant cohort ended up having RSV. It's so common, right? So if you could influence that by just even if you could influence that by a risk reduction of just a few points, and that vaccine should probably do even a lot more than that, you really could have a lot of impact on the healthcare system and then maybe long-term respiratory health. A huge finding here. And I think I'm really excited that these vaccines are out. I know I ran and got my infant son one as soon as he could and was eligible. And I'm happy to say he hasn't been diagnosed with RSV in his first year of life. This was really fun. I'm super excited that we're going to have this collaboration to talk about great articles like this, to hear about some groundbreaking research that really spans a variety of pulmonary and critical care topics. And we'll definitely be having more Journal Club authors on the show to review these interesting and timely articles.
Absolutely, Firth. This was so great. And just thinking about highlighting 4 very different articles that were very meaningful and highlighting authors and patient cohorts from across the globe, I think was really cool that we were able to do this. So we're excited to invite any fellows within our Pulm PEEPs network to reach out with us if you have any ideas. And if you have a few recent articles you want to review, we can discuss with you, and your submission can both be hopefully included in our collaboration with BMJ Thorax and a Pulm PEEPs episode.
Agree. I'm delighted to collaborate on this today. and excited for future work and episodes that we can do together. I will be delighted to hear from people with proposals for journal club submissions to Thorax, and people can get in touch with me if they want to hear more about how to do that and how to submit a Thorax journal club. Basically, the focus of a journal club is highlighting 4 research articles within the last 12 months or so. Ideally, there'll be impactful articles like the 4 that we've discussed today and based broadly around a theme like airways disease. And people can get in touch with me, can share my email address to do that with proposals, and I can give you help and guidance around choosing articles on a theme for Thorax and guiding you through the process and giving you further information. So if people do have proposals, I'd love to hear from them, and they can just drop me an email to do so.
Thanks, Chris. Yeah, we will share with this episode a link to these 4 articles. We want to give all the primary authors and the journals the credit well deserved. We'll also share a link to Imran's awesome summary. And if you want some more details, then you can read his journal club article. We'll share Chris's email, and then also you can reach out to us through all of our social media or our publicly available email if you're interested in doing this type of episode. So thanks, Imran and Chris, again for being on the show. This was a great episode. Thank you all for listening. Make sure you tune back in 2 weeks for our next episode. This episode was written, produced, edited by myself and Christina Montemayor. The music is original music by Eric Rogers, and we'll see you next time.